To get diagnosed with PCOS, you can kind of have two of the three Rotterdam criteria, which is missing or irregular cycle, often called cysts on your ovaries, or they say high androgen in the blood work, or symptoms of. When we think about PCOS being like a syndrome, what a syndrome is, it's like a collection of symptoms that might present, right? So it might be hirsutism or hair growth for some people, the acne for some people, the cycle irregularity, hair loss maybe. They are all different manifestations of having higher than optimal testosterone, right? So again, interesting to see the blood test results, but what we're actually looking at is, well, how is this manifesting for you, and what are the symptoms that are presented?
Even if it's not showing in the blood work, it doesn't really change the treatment plan for us because we can see how it's eating your body. Hello and welcome to PCOS Explained, formerly the PCOS Nutritionist Podcast. I'm your host, Claire Goodwin, a registered nutritionist and exercise scientist, specialising in PCOS because I have it too. Each week, we'll uncover the latest research, share inspiring stories, and provide practical tips to help you thrive with PCOS. Whether you're newly diagnosed, you've been struggling with this for a long time, or supporting someone with PCOS, this podcast is your go-to resource for empowerment, education, and community. So join us as we uncover the tools to thrive with PCOS. PCOS Explained is brought to you by our very own service, Ovi. Ovi is your go-to health service for women with PCOS. We help you improve your PCOS symptoms and prevent the long-term complications of PCOS by giving you hyper-personalised health advice based on your specific symptoms and PCOS drivers. We have a range of plans to suit your needs, from a DIY app-based program to one-on-one consultations. You choose what suits your budget and learning preference. And we offer a result-based guarantee on our Premium Plus plan, meaning that if we don't help you achieve your goal, we refund your money. Ovi is available worldwide, so it doesn't matter whether you're based in the UK, US, Canada, Australia, New Zealand, or anywhere else, we can still help you. So today we're talking all about testosterone. Now, testosterone is a hormone that is very normal to have in both females and males. But what can happen in PCOS is that we just get a little bit more than we need, and it can really disrupt a few things in the female body. So we're going to be talking a bit about what testosterone is, what it does in the female body versus the male body, how it could be contributing to your PCOS symptoms, why your tests might not be showing very accurately what testosterone is doing in your body, and what we can do about it. So first up, let's have a chat about what testosterone is and what it does.
So yeah, it's kind of interesting. I think lots of people think about testosterone and they're like, oh, it's just in males. And that's why I think as well, when you hear like in PCOS, you're like, oh, I have high testosterone, I shouldn't have any testosterone. Like you don't realize actually everyone does need testosterone, women included, because it does have some function in the body for sure. But yeah, in PCOS it just gets a little bit high. But testosterone is essentially just one of our hormones, one of our reproductive or sex hormones is what they're called. Yeah.
And also more than that as well, you know, it's part of a group of hormones called the androgen hormones. So testosterone's only one of them, and I think this is why we hear so much about it, because it is the most common, but it is only one. They're very similar in the way that they act. I call them like brothers from another mother, because they're very similar, but they're just produced in different parts of the body and can have a slightly different effect. But it is when you understand that that's a group as well, that you then know, okay, we're just not looking at just testosterone. There's these other ones called DHEAS and androstenedione, and that's where us as clinicians in PCOS will look at the whole picture rather than just focusing on the most common one, testosterone. But from mostly what we'll talk about in this podcast, just to make it a bit easier to understand, we'll just call them androgens. So know what we're talking about there is testosterone, but it is also these other hormones as well.
Yeah, definitely.
But I think what you were saying before about how when you first get diagnosed with PCOS, you hear about testosterone. And I know that I felt quite a bit of shame around that, because I felt like, oh my gosh, I'm more of a male, or this is abnormal for...
Yeah, or like I remember the first time I really thought about it or heard about it, my head went to those kind of like genetic things where you have like two X chromosomes, two Y chromosomes, you know, like the different chromosomal things, and so but it's not like that at all. It's just an imbalance or a slight elevation of a hormone that we wouldn't normally see across the board in females.
Yeah, exactly. It's not optimal.
It's not optimal, yeah.
And that's the thing. But unlike those other genetic chromosomal abnormalities, PCOS is at one point in time you have those elevated. It doesn't mean that that always has to be the case. We can do things to improve that, whether that's through lifestyle modification or medication. We can normalize those, but it's just telling you, okay, at this point in time, your androgen hormones are not optimal to allow the normal or optimal functioning of your body.
Yeah.
But the testosterone, as you said before, is really essential in females, and it is actually one of our most prevalent sex hormones alongside estrogen and progesterone, and it does some really important things. So some of the things that it does is it helps us grow bone mass.
Yeah, testosterone is often referred to as like an anabolic hormone. Like think about growth in the body or repair and things like that. Testosterone is kind of like a driving force behind those. Yeah,
so especially a lot of those, we call it lean tissue. It's like bone and muscle. Those are the things that testosterone is driving. And that's why actually those of us with PCOS, one benefit is that we might actually grow more muscle mass, which is actually really healthy to have higher muscle mass, and also maybe make us better athletes as well. And this is why we definitely see a higher prevalence of PCOS in athletes, because it is a little bit of a like performance enhancing.
Yeah, and naturally performance enhancing, not drug.
Yeah,
hormone.
Totally. Hormone. Naturally produced. But it's also really important for puberty.
Yeah.
It's one of the most important hormones for going through puberty, both in males and females. And it's actually what drives pubic hair growth. And because obviously kind of turning those like little villus hairs into terminal hairs, because that's what pubic hair is. And so it's really natural as well for both males and females to have higher testosterone going through puberty.
Yeah.
And this is exactly why PCOS shouldn't be diagnosed too early, because we might be looking at that and saying, oh, that's a high level of testosterone in this young female, but actually that's totally normal because she's going through puberty.
Yeah, completely.
So this is also why females can develop acne when they're going through puberty, because they have that high testosterone level. And again, that can be completely normal. It is quite hard, and I imagine especially as a parent, quite hard to determine when a level of acne is kind of normal versus something that needs to be addressed, especially in young females.
I went through that.
Yeah.
At high school, and it's interesting. I don't know, but I guess my dad has quite bad scarring from his acne, so that drove probably like an earlier treatment in terms of acne, and my mum was quite on the preventative side, but I can see in like a lot of other situations that might not be the case. And it would be quite a fine line to tread, I think, in terms of what that would be. But anyway, that is definitely something that is normal. Well, it is a normal response of what testosterone is doing in the body is actually triggering some acne. But when it comes to acne in like 20s and 30s, that's where it's like, okay, this is higher testosterone than is optimal at that age, and so therefore this is where we probably need to treat it. Yeah, and the reason why that testosterone is driving that acne is because when testosterone kind of gets into our skin cells, it can drive extra oil production. So sebum oil is produced in like our skin glands, and that high testosterone can drive more oil, causes the skin to get more blocked, and then causes more formation of like the acne pustules and things like that. So you can see how that would be quite normal when we have to have this kind of influx of testosterone through puberty to kind of change us into adults. But yeah, why that persists, or you hear so many people with PCOS just saying like, I can't believe I'm 35 and I still have acne like a teenager, like when will it stop? Yeah, and that's why it's that same, it is like a teenager because it is from the same production from testosterone driving that oil.
Totally. And the same thing with the pubic hair growth, right? The same thing's happening when you have hirsutism, which is facial or body hair growth, is that testosterone is getting into the hair follicle and turning a little peach fuzz, they're called villus hair, into a terminal hair. And that's why we can get that hair growth, is because it's the testosterone that's doing the same job. So same thing is that it's very normal to do that in the areas that are sensitive to testosterone in the female, normally sensitive to testosterone in the female body, which is like the armpits and the pubic axis outside the vulva. But what is less normal is when it's on the chin and jawline.
And those more male areas.
Yeah.
Male hair growth areas.
Totally.
Yeah.
But the reason that like males don't grow hair on their forehead, like the middle of their forehead, is because those cells are not sensitive to testosterone. So they'll never turn those hairs into terminal hairs.
Yeah.
Whereas that's the thing, is that still in females, we can be sensitive to that testosterone. It's just that normally, optimally, we don't have that extra testosterone to cause the
growth of those hairs. Completely.
I'm really struggling to say testosterone today.
Testosterone.
I remember this when I was recording my audiobook for getting pregnant with PCOS. There are some days that I could not say a particular word. And it would always be when it was a really common topic. Like I remember one was like sperm, and every time it'd be like smerm, and they'd be like repeat, and you'd have to like go back and like do it again. And there's literally, and when you're doing that, there is an editor that's listening to the whole time, and as soon as you kind of stumble over a word, they're like, okay, we need to do that again. So it was just like this constant, and as soon as you start to stumble, it then is like you can't, you just it's kind of all gone.
Yeah, you've got the anxiety.
Yeah. So testosterone. So that's the kind of the normal. Well, it is a normal way that our body responds to it, right? And it is totally normal. It's just that when we have higher than optimal levels as an adult, that's the repercussions of it, is we can get these very similar, I guess, experiences, or our body responds in a very similar way to what it would in puberty, but just not in the way that we want it to when we're older. It's also why it can disrupt our cycles. So when there is too much testosterone or androgens, that can really disrupt the very fine balance of our estrogen and progesterone and the other hormones that are involved in growing a follicle into an egg that we can ovulate with, and that then can be fertilized and then can implant in our uterus. And we've recorded a few other podcasts about this, so we'll point you back to the podcast about ovulation to understand this more. But I think all we need to really understand in this podcast is that testosterone does disrupt that balance, and then means that our body can struggle to ovulate or grow that egg to size.
Yeah. So I guess when you kind of think about it, when we think about PCOS being like a syndrome, what a syndrome is, it's like a collection of symptoms that might present, right? So it might be hirsutism or hair growth for some people, the acne for some people, the cycle irregularity, hair loss maybe, all of these symptoms. And it's like, they are all different manifestations of having higher than optimal testosterone, right? And so it's, for some people, their hair cells might be more sensitive to that testosterone, so that's why they present with hirsutism. Or for some people, their like LH or FSH or their ovulation hormones might be more sensitive, and so might present with that. For some people, you could get the whole lot, that high testosterone could be affecting all parts of your body. So that's kind of why all of these symptoms are classed together under the PCOS umbrella, because they're all products of testosterone affecting these pathways in some way.
And I think it's so important to understand that, because I have so many conversations with women who say to me, I'm not a typical PCOS person.
Yes, yeah.
Right? And I'm like, okay, this is something to understand, that there is no such
There's
thing.
no typical person. Exactly.
There is no typical person. Yes, maybe if you're looking at a medical textbook that was probably written or based on research from the 80s, they would be saying that a PCOS person looks like a higher body weight and facial hair growth, maybe hair loss, right? That is only one presentation. I present very differently. I don't have any hirsutism, facial body hair growth or hair loss, but do get the acne, the weight gain, and the irregular cycles. Like that was my picture. That does not mean that I wasn't a typical PCOS person. It just means that that's the parts of my body that were affected. Whereas someone else, it might be that they have hair loss but no hair growth, and they have completely regular, normal cycles and what looks like. So I think that that's such a crucial point to understand, is that there absolutely is no typical PCOS person. It is literally how your body is responding to this imbalance of this hormone.
Yeah.
And even more complicated is that not everybody has to have these higher androgen levels. Like this is also another, again, it's a little bit complex to understand this, and well then what would they present with, but again it's just understanding that this is a spectrum and people present with different symptoms. But I would say that 90% of people with PCOS would have these higher androgen levels.
And I think as well though, one thing to really think about with the testing piece, or like if you're like, well my blood work doesn't have high testosterone, so I must be one of those 10% that doesn't, but just be aware that we're only looking at like one metabolite or one finite version of, like we said, that family of testosterone oftentimes. So there's multiple different types that we could be looking at, or different ones might be higher for you, or they might not be in the blood, they might be localized to the tissue. So
totally. And we'll go through that in a little bit in terms of like why your bloods might not be showing high, because I think that is a really such a common question that we get asked, and so important to understand.
Yeah.
So going back to though the differences, I think, with males and female adults in terms of how why we present so differently with higher androgens. So that's going through puberty. We both have higher androgens, except that males will develop about 10 to 20 times more androgens than what females will. And same thing, we'll produce about 10 to 20 times more estrogen than what males will. Males will also have estrogen. But in males and adult males, testosterone works very differently. Testosterone, while it still grows your muscle mass, actually in males it makes them more sensitive to the hormone insulin, and therefore which controls our blood glucose. Now this is very different to the way that it affects females, and I think this is a very, very interesting genetic difference between males and females in the way that our chromosomes make our bodies react differently to these hormones. So in males, higher testosterone generally means that you'll have better insulin sensitivity, you'll be less likely to develop insulin resistance, and you'll be leaner as a typical kind of presentation. Whereas in females, higher testosterone actually increases belly fat, or like weight gain around the middle, which then increases our resistance to the hormone insulin, which means that we're more likely to develop insulin resistance. And also higher levels of what's called inflammatory cytokines, which are like inflammatory molecules released by our body fat, which can then further exacerbate insulin resistance. And I guess that's a really, again, common way that PCOS can develop, in that we have these high androgens, which then leads to insulin resistance, which then leads to more androgens, more like belly fat or higher weight gain, which then leads to more testosterone, more insulin resistance, and it's a bit of a vicious cycle in females. So that's, I guess, the really important thing to understand, that PCOS, especially that testosterone, works very differently in females. So then going into the normal levels in women, what would they be? Like, because I think that would be my next question if I was listening to this, is going, okay, well, what is a normal level in women? And I think that these will differ all over the world, and you'll see it if you get a blood test result and it will just show the normal range. But I don't think that really matters, and the reason for this is because in females especially, it's often not accurate. So what will often be measured is something called free testosterone, and free testosterone is the testosterone that's floating around in our bodies. So we've got to understand that with all hormones, they're there to do something in the body. So they're there to go to a particular tissue. So hormones are our body's emails. They are telling different tissues or organs in our bodies to do something. So testosterone is traveling in your blood and it's going to your muscle cells and it's saying, hey, you need to grow bigger. Or it's going to our bones and saying, hey, you need to lay down more bone, get stronger. This is your prime time to be growing bone. This is what you need to be doing. Or it's going to our, as we said before, it's going to that tissue, our oil glands, and saying, hey, you need to produce more oil. Whether that's the right thing to do or not, it's still telling that tissue organ to do something. So all hormones act in this way. They're all just emails that our body's sending to tell it to do something. But that is when they are so in the blood floating around. It's kind of like once you've sent the email off, we imagine there was like a test that was intercepting all our emails at the time we click send before it actually reaches someone else's inbox. That's what we're measuring there, is measuring, okay, how many emails are in the ether at any one point in time, right? Is that really relevant? Like, kind of not, because actually what is important is when it kind of hits that other person's email inbox. Or same thing with us, when we measure free testosterone, it's like we're measuring it at one point in time, what's in the blood, not necessarily what's connected to that tissue and telling it to do something. So I think that that's one reason why it is not often, as you said before, you might get you might get your testosterone tested and it comes back low, why that is not really that accurate.
Yeah, so like as you said, looking at those levels at one point of time isn't really going to give us like a great picture of like, well, is there actually across our whole body elevated testosterone, and is this like causing an effect? And like we said, you know, if we're looking at just our free testosterone at that point in time, that's also not telling us, you know, what DHEAS, which is another one of those androgen hormones that you talked about, or androstenedione. We don't know what those levels are as well. And as well, some of these hormones can have metabolites and different versions of them. So we're not also testing, you know, the different breakdowns of these too.
What's a metabolite? I think that's quite an interesting thing to talk about.
Yeah, so a metabolite is like a broken down version of something. So if we think about, we eat an apple and it has sugar in it, or fructose, and when we need to digest that, it all gets broken down into individual little molecules so that we can absorb those into our bloodstream. So, you know, the glucose, the fructose, whatever, they are like metabolites, I guess. So the same thing kind of happens with some of our hormones as well. There are different conversions of different hormones to break them down, so then they have different roles again within the body. So you might have, you know, the big daddy testosterone here, but there can be conversion processes that happen. One that actually is what we really want to understand and know about, which is the one that tends to cause a lot of these, you know, acne, hirsutism, all of those kinds of symptoms, is actually a molecule called DHT. And that is the one, the metabolite of an androgen that is really driving a lot of these symptoms. So that DHT molecule might have been metabolized so that it is ready to act on the cells in say our skin or in our hair follicles, because maybe testosterone can't get there, or those skin cells don't have the right, say, receptor to fit testosterone, but it does for DHT. So DHT kind of breaks itself down so that it can do its action.
Absolutely. And actually, the really interesting thing with PCOS is that it's pointing maybe that androstenedione may actually be a much better predictor or marker for androgens in PCOS, which I think is really interesting because it is so infrequently
tested.
Measured.
Yeah, I don't think I've seen many blood tests with
and it is, and it can be harder to get. And I'm not saying that you guys need to go out and get these tests. I'm just saying why we might look for different things, or we don't often even test for androstenedione either, but we know what other clinical symptoms to look for. And that's why in PCOS we very rarely, if someone's like showing us that they have acne or hirsutism or hair loss, for example, even if they have low testosterone, we wouldn't care.
No, and that's the thing is, like, you know, people are like, oh, but I haven't got my testosterone results, and I'm like, I'm not really looking at that. I don't really look at that. It's like I just see them and I'm like, oh, hi, interesting, cool. Not hi, interesting, cool. They don't inform how I work with a client. And I think it is good to know as well. And, you know, you might feel like, oh, well, but I need to know, like, if I've got high testosterone. And for, like, a diagnostic criteria, maybe. So, you know, to get diagnosed with PCOS, you can kind of have 2 of the 3 Rotterdam criteria, which is missing or irregular cycles, cysts or baby follicles, but often called cysts on your ovaries, or they say high androgen in the blood work, or symptoms of. So even in that diagnosis, you know, some doctors might say, oh, well, you know, you don't have high androgens in the blood, you know, we're not going to diagnose you. But really, the Rotterdam criteria does say it needs to be either the blood test or symptoms of. So again, that's exactly what we've just said. Interesting to see the blood test results, but what we're actually looking at is, well, how is this manifesting for you, and what are the symptoms that are presenting? Yeah.
And as we said before, it is commonly accepted that probably about 90% of people with PCOS are going to have these high androgens. And so again, even if it's not showing in the blood work, it doesn't really change the treatment plan for us, because we can see how it's affecting your body, and we're more looking at, okay, what do we do about it now, right? It's like, okay, you've got these symptoms, how do we improve those symptoms? Not necessarily, okay, we need to know all the ins and outs about like what your androgens are doing. Sometimes it can be helpful, and sometimes if someone's really struggling to get a diagnosis, we'll write their doctor a referral letter and ask for very certain tests, and we can do that, but it isn't often necessary. And I think it can also just lead to a lot more sort of stress and not really productive time from your part in trying to go after these particular tests, because again, we're just going to look at that and go, okay, cool, interesting. Right, what do we do about it now?
Yeah.
And that's way more important for us.
And if you are really having to like navigate with your doctor, your primary healthcare provider around testing particularly, these would be the ones like probably not, don't waste energy on pushing for those. There are more important things that are going to help symptoms, which might be like nutrient levels or other hormones that we might want to look at that might be contributing. But really actually knowing what your testosterone levels are, like we said, in most cases isn't hugely necessary.
Yeah, and not a productive use of your time in most cases. To give you an example of this, I had a patient called her B. She had really significant facial hair growth, and yet her testosterone was showing as low on her blood work, but she had irregular cycles. She fit the criteria, and she went to see her doctor, and he said, you don't have PCOS because your testosterone is low. And that point, I counselled her and I said, look, you do. Not that it's not my lane to diagnose people, but here's the criteria. You fit that criteria.
The doctor's misinterpreted.
Yeah, that's right. He didn't really understand. He was a general practitioner, and he's got so many conditions to understand. He didn't really understand that. And so she was really worried. She came to me and she said, I don't know if I can work with you anymore because I don't have PCOS. And I was like, why is that? She was like, I've got really low testosterone, so I don't have PCOS anymore. And so I explained to her that you still fit the criteria. And also, even though we specialise in polycystic ovarian syndrome, I'm not treating a diagnosis, I'm treating your symptoms.
Yeah.
So I'm looking at, okay, what's causing this high facial and body hair growth? What's causing your cycles to be irregular? Let's look at the underlying drivers of these symptoms, and then let's create a treatment plan to treat those.
Because when you think about it, it's like you guys don't really care, and like if we do all of this work to reduce your blood testosterone levels, like that's not what we're doing it for. We're doing it to reduce how it's manifesting.
Totally.
So
you don't care that your testosterone's improved by 5 points because you've still got just as much facial and body hair growth.
Exactly.
It's like, okay, cool, nice, but also not
nice. Yeah,
didn't really meet my criteria.
It's just that interception of what's in the ether at that time.
Yeah.
So it really, could be 5 points today, could be 10 points tomorrow. It changes all the time. So
yeah, and also too, it's just when you do a blood test, there's something called specificity, how specific something is and how sensitive something is. So when you do any test, so even like a pregnancy test, right? A pregnancy test, actually, when you're looking at it, it's like, okay, how specific is it for that symptom, i.e. pregnancy, and how sensitive is it, i.e. if it is over this level, how confident are we that that means you're pregnant? So for example, with those pregnancy tests, they're measuring HCG hormone. That is very specific for pregnancy and very sensitive. So you'll very rarely get a false positive pregnancy test. Very rare. Even through urine. Yeah, even through urine, it's really rare to get a false positive. So it's really that's a high, whereas testosterone is much lower in terms of that it's specifically saying, okay, yeah, this is definitely what we see in the blood is definitely going to mean that you're not going to have symptoms or you are going to have symptoms, which means like in B's case, it was not actually relevant to, she was presenting these symptoms with the facial hair growth, but yet the blood work wasn't sensitive enough to pick up that was high.
Yes.
So
exactly.
yeah, so
and
I think
it kind of comes down to all the metabolites and all
Yes.
the things like that is the reason. Yeah.
Yeah. And the other thing that is also really important when we're measuring testosterone or androgens is knowing your age, because that also declines throughout age. And as I said before, can be higher is very commonly higher in teenagers, and especially those going through puberty, because it is what's driving your sexual reproductive growth, right? It's as you said before, it's helping to make you into an adult. And so that's really common to have high testosterone in teenage years. It can also be common to have high testosterone after coming off the pill. And so if you've got a diagnosis after coming off the pill, this could be why you have like temporarily high testosterone as well. Is because when we're on the pill has got lots of, depending on what kind of pill you're on, but if you're on a anti-testosterone contraceptive pill, it's got lots of sponges in it which go around and mop up testosterone. This is called sex hormone binding globulin, and they are literally sponges for testosterone. So the pill is giving you all of those, and so when you stop taking the pill, you take away all those sponges, and so then suddenly we've got all this testosterone floating freely about the body, like
Wreaking havoc.
Totally. And this is why a lot of people get like a backlash of acne after coming off the pill or other symptoms, is because we've had all this
post-pill kind of PCOS is what it's often deemed, isn't it?
Yeah.
Like a showing of symptoms that maybe haven't even been there before. Yeah.
Totally. And this is where, you know, we look at what your symptoms were like before going on the pill and after, and sometimes it can be a bit of a temporary state, but also sometimes it can be, oh yep, this is what your hormones would be if you weren't on the pill, and so this is actually a true value. So that's another one.
Especially if you started taking birth control when you were 15, like during that puberty time, it's like we actually never really knew what your cycles or your hormones were like before the pill, because you might have been on them for like the last 10 years, and so we haven't actually seen what your testosterone levels are.
And that's also another thing, like I see so many people, and again their GP doesn't understand because they're not an expert in this area, they've got so many conditions to know about, but they send them for a testosterone test but never actually ask or look at whether they're on the pill or another hormonal contraceptive. And so if you're on hormonal contraceptive and you're getting your testosterone levels taken, they're not really an accurate reflection. And it might be that they're artificially elevated because you're actually on a pro-androgen pill, or they might be artificially reduced because you're on an anti-androgen one. But it's very, they're not accurate if you're on any hormonal contraception. And then the last part of that is, we're talking about age, is when we get closer to perimenopause and menopause, then our testosterone can decline as well. Although generally we'd still see that even though it's declining in lots of people with PCOS, you'd still be at the higher end of that, an optimal range.
Yeah, and that's why we still see PCOS symptoms kind of be present even post-menopause. And, you might think, but PCOS is to do with ovulation, and it's a kind of with sex hormones,
fertility and periods.
But, all of those testosterone specific symptoms, even though it might not be affecting your ovulation anymore, it's still going to be affecting all of those other, like that middle band weight gain, hirsutism, acne, even those sorts of things. They can all be still affected even once, ovulation shut down and you're in past menopause. Yeah.
And so two things there. One is the reason for that you can have it after menopause is because even though your kind of ovaries shut down and they're not really producing testosterone anymore, testosterone and androgens are not just produced by your ovaries, they're also produced by your adrenal glands, so where your stress hormones are produced, and it's also produced by your liver and your fat tissue. So as I was saying before, that if you've developed some insulin resistance, or testosterone's caused us to gain like belly weight, and then that then leads to insulin resistance, and then you get more testosterone, more insulin resistance, more belly fat, then that's going to continue through menopause unless we treat it, and potentially get worse because we get more insulin resistant after menopause as well. But I think that the other thing I did see was another patient. She was going through perimenopause and she'd actually been put on testosterone.
Yeah, I've had a patient who's been put on testosterone as well. Yeah.
Again, I had to kind of write just a referral to a doctor and be like, are you sure this is the right hormone? Because she's already, and she was presenting with higher androgen symptoms like facial hair. Her big thing was facial hair growth. So she was coming to me to improve that symptom, and yet was taking a hormone that was actually driving that.
Yeah.
And so again, it's that if there's a bit of a misunderstanding about, they're just looking at your overall testosterone levels, and she was lower on that testosterone, and she was presenting with other symptoms which are often thought of as low testosterone symptoms, like low libido and vaginal dryness, is that, unless a doctor really truly understands that full picture and exactly how PCOS works and why maybe the androgen test is not accurate, they may still put people on testosterone, even though that's completely the wrong thing to do in this case. I would say in most cases. So if you're going through perimenopause and your doctor has put you on hormone replacement therapy, which includes testosterone, really question that, especially if you're getting any of those testosterone symptoms. That is it may be the right thing, absolutely, but I would say in 90% of cases it's the wrong thing.
The wrong thing to do, yeah.
Totally. So to finish this off, we'll quickly go into a bit about the treatment side of things, and we explain this a lot more in depth in our podcast about drivers, what's driving your PCOS. Formerly we called this the root cause. So we'll link you to that as well. But just as an overall, as we said at the start, it's like this is your body's overproducing these androgen hormones. It's at one point in time. So it doesn't mean that this will always be the case for you, or has to always be the case. There are many things that we can do to actually reduce that. So the most common that you'll get told about is what I would term like blunt force ways of reducing this, and this is generally medications that are doing this. We talked a bit about the pill before and how that can have these sponges in it called sex hormone binding globulin. So the pill is I would say 100% is the most common treatment for PCOS that's given to people. Not necessarily the right treatment, but it is the most common treatment and common thing suggested. So one of the ways, and rightly so, it can reduce those androgens, especially if you're on the right pill.
Yeah, the right one, exactly. Yeah.
And so, yes, that's a thing to know, is that they're not all of them. There are hundreds of different types of pills, and they're all got different amounts of, especially the hormone progestin in them, and different kinds of varieties of that progestin, which is the synthetic form of progesterone. And this can either be pro-androgen, like I increase your testosterone levels, and the very early versions of the pill that were released in like the 50s and 1950s and 60s, they were very pro-androgen. So they are not great to use for PCOS. They're going to make those symptoms of the acne. It's kind of
like taking, like we were saying, in most cases, taking testosterone is never a good idea, or taking something that's going to drive up testosterone probably isn't going to be a good idea either. Especially when there are other options, right? Yeah.
Totally. And that's also, it's not just the pill, it's the like Depo-Provera injection, really bad for that. The arm rod, really bad for that as well, and the type of pill. But if you're on more of a pill like Diane 35 or Yasmin, the type of progestin that's in them is anti-androgen, and so it's going to give you more of those sponges, those sex hormone binding globulin, to go around and mop up the testosterone and temporarily decrease the testosterone that's in your body available to go to your cells, like your sebum glands in your skin, your oil glands, and produce acne, or your hair and cause hair growth, or your hair in your head and cause hair loss. We didn't even talk about that, but very similar way that it, well, actually opposite way, goes to the hair in your head, especially around your crown of your head or your hairline, and the DHT actually kills that hair follicle, causing it to fall out. So this is why it can cause the very unfortunate effect of losing hair on your head, but then also causing hair to grow on your body where you don't want it, and a very devastating combination of symptoms for a lot of people. So that's the pill then goes and mops up that extra testosterone and kind of renders it inactive. It's like a
I think about it like a Pac-Man.
Yeah.
Goes around and like gets them all, and it's like, oh well, you can't.
Or like a police paddy wagon, and goes around and like bundles them in and like shoves them in the van, and it's like, you can't do anything now, you're locked up. But it's only working while you're on it. Yeah. So when you come off, you're going to have a rebound of those symptoms, unless we work on the underlying drivers, and so stop your body doing that. I think about it like your child, specifically thinking about my toddler in a couple of years, I can imagine this, is like going to the bathroom, putting what we're doing, we're like putting the plug in the sink and then turning the taps on. That's kind of what's happening to your body at the moment with testosterone. Is like we've put the plug in, your body can't really get rid of that testosterone, and we're just turning those taps up. And soon the basin will overflow. And that overflow of testosterone in our body is then what's wreaking havoc. It's so much and it's causing these issues. So what we're doing with the pill is that we're just going in there, but instead of actually turning the taps off, we're just keeping them going full bore, and instead we're just throwing towels and sponges into the basin to try and mop it up and stop it from overflowing. As soon as we stop taking the pill, we just stop putting all those sponges and towels in. We don't have them anymore, and so the testosterone is just going to overflow into our body. What we can do though in the meantime is we can actually start to turn those taps off by addressing the underlying problem in your body, what we call the PCOS drivers. So we look at what's actually driving that high testosterone. Is it the insulin, your blood glucose hormone? Is it your stress hormones? Is it your thyroid? Is it chronic inflammation? Is it a combination of a lot of those? And then, well, what would be the lifestyle steps that we could take and or medication that we could use to actually reverse those?
Yeah, because like we can do both. We can be padding the overflow, maybe like opening the drain a little bit, putting the towels in around, but at the same time turning down those taps so that when we're ready to take away the sponges or put the plug back in, your sink won't overfill again. Yeah,
and therefore you'll have a lot less of those androgen symptoms when coming off the pill. And a lot of people, you've gone on the pill for a certain reason, like your acne was really bothering you, it was really problematic, and so you've gone on that, and so we want to make sure that we don't make that worse when coming off the pill, but actually make it better. So that's one of the blunt force ways. Another blunt force way would be another anti-androgen medication like spironolactone, and works a little bit differently to a progestin, but all you need to know is that it does decrease that testosterone. Kind of the good thing about Spiro is that you can wean off it, and this is what we see, or what we work with people doing with their doctor, is that while we're working through these underlying treatments, we could reduce, or their doctor could reduce that Spiro down a little bit, whereas the pill's all or nothing.
Yeah.
It's either you're taking it or you're not taking it. You can't just kind of take it every second day, or whereas Spiro, it could start on like, I don't know what the milligram dose is, but say it's like 500 milligrams, and then it goes down to 200 milligrams, and then 100, and then 50, and then you know, while you're working through these changes over the course of say 6 months.
Yeah, and I think as well you might look to something like spironolactone as well as a medication if you don't want kind of the reproductive repercussions that come along with, like, say, the birth control pill. So whereas Spiro's not really affecting your ovulation, say, like
it can sometimes, but but not common. Well, not as common, right?
Yeah, I've never seen it.
Haven't you?
No.
No, I've seen Spiro affecting ovulation.
Maybe a high dose, yeah. Yeah, another reason why you might want to use Spiro as well is that unlike the birth control, which particularly if you're using like an anti-androgen one, is going to shut down ovulation. We know that that's what it does, the combined pill. But Spiro in most cases won't really affect your ovulation, so you can be getting the anti-androgen benefits without typically affecting your cycle.
Yeah. And there's also another anti-androgen which we might use as well, very similar but may actually be more effective than Spiro, but again in many cases doesn't affect your ovulation, allows you to ovulate and get that back. Because again, for so many people, they're like, well, I've heard you now talk about how I've been put on the pill to regulate my period, but I now know that it's not regulating ovulation, it's actually completely shutting that down. And so I do want to fix that. Like, I want to get my cycle back for health or for fertility or for both those reasons. But I also, the acne is too bad for me at the moment, so I need to be on something. And so it's like, great, this is a really good alternative that you could start on that while you're working through the underlying changes, what lifestyle changes. It may take 3 to 6 months to see improvement, and you don't get that androgen backlash like you would if you just completely cold turkey stop the pill. So that can be a really good intermediary way. It's not without side effects though, and so a lot of people, the side effects don't work for them, or they're not willing to take that risk. With Spiro, you can't be trying to conceive, because it is an anti-androgen. If you did conceive a male baby, it might affect the normal kind of reproductive development of that male baby, and so you really need to be in a position where you're definitely not trying. So those are the kind of the blunt 4 ways we can reduce testosterone. The other way that we like to look at it is we're very supportive of you using medication if that's what your choice is, but we're always wanting to actually fix the problem as well. So as I said before, we'd always look to that underlying drivers, like how your blood sugar and insulin's functioning, how your stress hormones are functioning, your thyroid, and then look at what we can do to intervene there and make them more optimal so that they're not affecting your testosterone as much.
Yeah, and we'd cover all of that in the Drivers podcast. So definitely go have a listen if you haven't to that. And that's exactly what we cover in OV and all of our lessons. Yeah.
Absolutely. That's exactly what OV is. And what we do with all of our patients is we first identify what is that thing that we can change for you. So what is that thing that's not optimal, that's driving this high testosterone, driving those symptoms for you, and what are the treatments that are actually going to lower that? So it could be for you tweaking a couple of things in what you're eating, how you're moving, maybe it's actually focusing on your sleep, maybe it's some nutrient levels that aren't optimal, and also other medication that can also help those things as well. So maybe it's a thyroid condition and you need some thyroid replacement hormone, or maybe it's that it's an insulin issue and you could benefit from some insulin medication if that's the way that you want to go. So we give you all the options, we tell you what the problem is, what you can do to fix it, you get the options, and then you choose how you want to treat that. We are completely agnostic and just provide you with all of the pros and cons of each and then help facilitate you into getting those.
Yeah, and kind of figuring out what's the right fit for you.
Yeah, because just like how PCOS symptoms can present differently in everybody, the right treatment is also different in everybody because your situation, your circumstances, your
preferences, your lifestyle,
your past history.
Yeah, exactly. Yeah.
So if that sounds like you and you want more, then head to ov.io and have a look at all of the options that we can provide you in terms of getting that right treatment for you. If you're finding value from these podcasts, then we'd be so grateful if you could hit follow on the PCOS Explained podcast. This means that not only you'll get the latest releases, but also that other people are more likely to find this podcast. That's the way the algorithm works. And we all know how important it is to get good information about PCOS. So if you can hit that follow button, it means that people with PCOS that don't know that this podcast exists are more likely to find it. So thank you so much for your help there. Now stand by for our disclaimer. The information contained in this podcast has been prepared for the purpose of providing information, including about the PCOS nutritionist products and services, and is designed to support clients' overall wellness. It is not intended to provide medical advice or designed to rectify, treat, or cure any specific medical conditions or diseases. Nothing stated or shared in our podcast is intended to be and must not be taken to be medical advice. Please seek the advice of professionals as appropriate regarding the evaluation of any specific information, opinion, advice, or content contained in our podcast.